Welcome. In this explainer, we're diving straight into a focused review of the evidence behind perioperative antibiotic prophylaxis in gynecology and obstetrics. Our goal is to really break down the current guidelines for critical procedures, making sure our practices are maximizing patient safety and, of course, promoting smart antimicrobial stewardship.
So, here's our roadmap. We'll start with the core principles of prophylaxis and the specific microbes we're targeting. From there, we'll get into the nitty-gritty of protocols for Caesarean sections, some highly specialized fetal procedures, and other common gynecological surgeries. We'll wrap it all up by looking at why this is so fundamental to patient safety.
All right, Section 1. At its heart, surgical prophylaxis is all about preventing surgical site infections, or SSIs. Now, let's be clear. The goal isn't to create a totally sterile surgical field. That's just not possible. The real strategy is to get enough antimicrobial agent into the patient's tissues right at the time of incision to stop microbes from getting a foothold and causing an infection.
And just so we're all on the same page, let's define this precisely. Perioperative prophylaxis is for patients who show no signs of infection before surgery. This is what makes it so different from treatment, where you're fighting an existing infection. Here, the goal is purely preventative. We're anticipating the contamination that's a natural part of any procedure.
An effective strategy really rests on 4 key pillars. First, you have to select an agent that actually works against the most likely culprits. Second, and this is so important for antimicrobial stewardship, you want to pick an antibiotic that's not your first choice for treating active infections. That helps us fight resistance. Third, and this might be the most critical part, timing. That dose needs to go in 15 to 60 minutes before the first cut. Why? It's all about pharmacokinetics, making sure tissue levels are at their peak right when you need them. And of course, you repeat that dose for longer surgeries.
So, to be effective, we have to know our enemy. Understanding the potential pathogens is absolutely essential. And this microbial landscape, well, it changes pretty dramatically depending on where in the body we're operating.
This table gives us a great overview. You've got Staphylococcus aureus. It's on our skin, so it's a risk for pretty much any procedure that involves an incision. Then for abdominal surgeries, we have to think about gram-negative Enterobacteriaceae from the gut. And finally, when we're dealing with procedures that involve the vagina or intestines, we absolutely have to cover for anaerobes. Now let's turn our attention to one of the most common surgeries in obstetrics, the Caesarean section. The protocols here have actually changed quite a bit over the years, especially when it comes to when we give the antibiotics and how we think about risk for elective versus non-elective procedures. And that brings us to a really important clinical question. The risk of infection, things like endometritis or wound infection, is way different for a scheduled C-section compared to an emergency one. So what does the evidence tell us? How do we adapt our game plan? The protocol split right here, based on that risk assessment. For an elective C-section, the main concern is skin flora. A single dose of Cefazolin before the incision is enough. But now, think about an emergency C-section on a patient who's already in labor with ruptured membranes. The surgical field is now potentially contaminated with a whole different set of microbes from the vagina and amniotic fluid, including a much bigger load of anaerobes. So the protocol has to escalate. We go to a dual-agent regimen, Cefazolin plus Metronidazole, to get that necessary broad-spectrum coverage. Now, there are a few other important details here. The move to pre-incision administration, instead of waiting until after the cord was clamped, was a huge step forward. It's been shown to dramatically reduce maternal infections, and while people have wondered about the effect on the baby's gut microbiome, big studies haven't found any clear long-term problems, and the benefit to the mother is just too great to ignore. And of course, if there's a beta-lactam allergy, clindamycin is our go-to alternative. Okay, let's shift gears a bit. We're moving from C-sections to procedures designed to save a pregnancy, like a cervical cerclage or interventions for fetal issues. In these cases, preventing an infection that we cause is absolutely paramount.
For a cervical cerclage, the protocol is really straightforward. It's a single pre-operative dose of Cefazolin. The logic is simple. We want to target the bugs most likely to be introduced from the vaginal canal during the procedure, which are mainly streptococci and enterobacteria.
It's a similar story for a highly invasive procedure like fetoscopic laser treatment for twin-twin transfusion syndrome.
Even though it's minimally invasive, entering the amniotic cavity carries a huge risk of chorioamnionitis. So again, Cefazolin is the standard of care, giving us coverage against skin flora like S. aureus and any potential pathogens moving up from below.
Now let's broaden our view to other common GYN surgeries. You'll see a consistent theme here. Whether we use prophylaxis and what we use is all based on a careful assessment of the infection risk for that specific procedure.
This list really highlights that risk-based approach. Notice the pattern? For major procedures that enter a potentially contaminated area, like a hysterectomy or a big prolapse surgery, we need broad-spectrum coverage, Cefazolin plus Metronidazole. But for clean procedures, like an isolated groin surgery, you typically don't need any prophylaxis at all. And it's also crucial to see where the evidence just isn't there, like for routine prophylaxis with manual placental removal.
Now, this is a fantastic example of why evidence-based practice is so critical. For a first trimester instrumental abortion, prophylaxis is indicated to lower the risk of infection spreading to the upper genital tract. But for a miscarriage curettage in a low-risk patient, the evidence just doesn't back up routine use. It shows we can't just lump similar-sounding procedures together. We need data for each one.
And for that first trimester instrumental abortion, the evidence points to a very specific regimen, a single 1,000 milligram oral dose of azithromycin. It provides excellent coverage against chlamydia and other key pathogens.
Laparoscopic procedures also require some careful thought. A quick, simple diagnostic lap, that's a clean procedure, no prophylaxis needed. But if it's considered clean contaminated, maybe it's a long procedure or you're using mesh, then prophylaxis with Cefazolin is warranted. And if there's ever an accidental bowel injury, the whole case gets reclassified as contaminated, and you've got to immediately add Metronidazole to cover those gut anaerobes.
So as we start to wrap this up, you can see how all these individual protocols come together to form a comprehensive framework. And this framework is absolutely fundamental to patient safety.
And this really is the key takeaway. The judicious, meaning thoughtful and evidence-based, application of perioperative antibiotic prophylaxis is a true cornerstone of modern patient safety. Getting it right depends on understanding procedural risk, knowing the microbial landscape, and having a commitment to changing our practice as new evidence comes to light.
And that leaves us with one final and very important question. As we all face this global challenge of rising antimicrobial resistance, how do we make sure these vital, evidence-based protocols continue to evolve? How do we ensure we can protect our future patients just as effectively as we protect them today?